So welcome to everybody. Welcome to our first webinar. There will be 7 webinars in these weeks. So if you want to obtain your certificate, you must assist into 4 webinars for you can get it, okay? In order to get your certificate as an assistant, you must have all the registered in a Google Forms. The Google Forms is gonna be written down in the chat. I'm gonna send you that and you can do it. So first, I want to continue and I would like to present Dr. Leonel Garcia, who is going to present this webinar. Thank you, Dr. Leonel, and I'll give you the word.
Hi, everyone. Today we're going to start the webinars for CUT. My name is Leonel Garcia. I studied in CUCS. I'm also from the University of Guadalajara. And today I'm going to present you a topic that I think as general doctors, general practitioners, is very important, that it's cardiovascular physiology, specifically talking about the mechanical activity of the heart. That it's what the topic we're going to be reviewing today. So the questions you have or something, we can answer them at the end, please. Everything through the chat. And I hope you like the presentation. Okay, can everyone see what the presentation?
Yep. Yeah.
Yep, perfect.
Yes.
Okay, so we're going to start with mechanical activity of the heart. As we know, the heart is one of the most important organs in the body. Why is that? If we consider the body as a whole, as a machine, let's say that, then the brain would be the computer, but the engine, the thing that pumps the fuel to everything, would be the heart. Okay, so that's the important aspect of a heart. It's gonna pump blood everywhere. It's what's gonna give oxygen and all the nutrients to the different tissues of the body. So that's the importance the heart has. Okay, so let's review the anatomy real quick. It's just something simple. As we know, the heart is divided into 4 different chambers, 2 atriums and 2 ventricles. Okay, these ventricles are separated by a septum, and the atriums and the ventricles are separated by fibrous tissue. This is going to be very important later, so please memorize it. What other things are important? They're also divided, the ventricles from the atriums, by valves. Okay, mitral valve and the tricuspid valve are the AV valves, the atrioventricular valves. Okay, and the semilunar valves are going to be the pulmonary valve and the aortic valve. This is going to make the heart divided into 4 different chambers. So just imagine a square and divide it into 4. Of course, we know the ventricles have a bigger size than the atriums, and the left chambers of the heart are also bigger because they have the responsibility of pumping blood everywhere else. Okay. Okay, so what is cardiac muscle? First, let's start by the components of the machine. The machine is made by cardiac muscle. Why is it different from other types of muscle? We're going to review in a while, but first of all, there are 3 types of cardiac muscle. There's atrial muscle, there's ventricular muscle, but there's another part of cardiac muscle that's very important. That's the conduction system of the heart. This conduction system allows the heart to have a rhythmicity and to trigger action potentials unlike any other organ in the body. Without intervention, it can by itself trigger different action potentials and have a rhythmicity that other tissues don't have. Okay, these specialized heart muscle cells can generate a pacemaking signal and cause the contraction of the heart. Another part of cardiac muscle that's very important is that it acts as a syncytium. What's a syncytium? If you have reviewed this topic before, maybe you have kind of an idea that muscle cells, cardiac muscle cells, don't act as any other muscle cell in the body. Individual cells actually function as a unit. So one cell does nothing. You need a whole bunch of cells stuck together, joined together, to travel that action potential and cause contraction, so we can pump all the blood out of the chambers. How do these action potential travel? It's thanks to this intercalated disc. Okay, this intercalated disc are the membranes of the cardiac muscle cells joined together, stuck together against one another. So the action potential travels from one cell to the other, causing the contraction to occur as a whole. So that's the difference. And how do these intercalated discs, how do these membranes can pass the different ions, so the action potential can travel? It's thanks to gap junctions. Okay, that's the importance of the cardiac muscle cell. Gap junctions are the ones that allow the free exchange of substances. Another important part of cardiac muscle cells are desmosomes. Desmosomes anchor the cells together to provide a tensile strength, so they can be joined without any damage occurring to them. It has a large number of mitochondria. That's something important also about cardiac muscle. And how much does it consume of oxygen? Because you know oxygen triggers all the reactions in the body. It consumes about 9 milliliters per 100 of grams of cardiac muscle, 9 milliliters per 100 during rest. So this consumption is gonna exacerbate during periods of stress, such as exercise or any other kind of stress that's put into the cardiac muscle. Okay. As we said, as in syncytium, action potentials can travel from one cell to the other, letting the action potential pass through the intercalated discs, but not all the heart is a syncytium. There are two different syncytiums, atrial syncytium and ventricular syncytium. Why is that? Because we need different contraction periods in the heart, so the blood can pump through first from the atriums to the ventricles, and then from the ventricles to the body. So we don't need the heart to just boom contract as a whole. We need first the atriums to contract, to pass the blood from the atriums to the ventricles, and then the ventricles to contract. So there needs to be a delay. That's why atrial syncytium and ventricular syncytium are divided. They're divided by the fibrous tissue that we talked about before. That's a ring of fibrous tissue that separates the atrium syncytium and the ventricular syncytium at the atrioventricular junction. Okay, so at the AV junction, there's fibrous tissue that won't allow the action potential from the atrium to pass to the ventricular syncytium as a whole. However, if you remember some of the physiology you've seen in the semester, you will remember there is some part from the AV node that travels through his node and then goes to the rest of the heart. Let me just go back a few slides. As you can see here, the sinoatrial node is going to make the depolarization, the action potential, travel first through the branches, the Bachmann branch, Wackenham branch, Thorell branch, to the atrioventricular node. But then Hiss's bundle, that's right here, Hiss's bundle is the one that's gonna allow some of that action potential with a delay to go to the ventricular syncytium. So that's the way they connect. They don't connect as a whole. They connect just through one single bundle. So that delay can happen, and the contraction is able to occur First in the atriums and then in the ventricles. That's very important for the physiology of the heart. So please remember, okay? Okay, so how does cardiac muscle cells contract? Calcium is a key important in this reaction, in the contraction of muscle cells. It's very similar to the reactions you've seen from skeletal muscle. The contraction is practically the same. The strength of the contraction is going to be related also to the amount of calcium being released by the reticulus and the plasmas, okay? ATP is going to bind into the myosin head, where it's going to be hydrolyzed into ADP and pipe. This reaction is going to provide enough energy for the movement of the myosin head that's going to create the powder strut. Then the myosin is going to shorten the sarcomere. The sarcomere is what we call the whole unit of different muscle fibers, muscle cells, muscle fibers joined together. It's going to contract the sarcomere and allow for the muscle contraction by shortening it, okay? What's the action potential of cardiac muscle? Cardiac muscle has an action potential from negative 85 millivolts to minus 90 millivolts, okay? It's gonna go from minus 90 approximately to 20 millivolts. So it's gonna be 105 action potential if you calculate all the volts at which it occurs. It's gonna be similar but different to in just one aspect to any other cell. What's gonna be different is that a plateau is gonna occur. If you can see right here, a plateau of about 0.2 seconds, it's gonna occur right here. So the ventricular contraction is gonna last about 15 times more than what it does in the skeletal muscle. This is very important, so the contraction can occur with more power. Ventricular and atrial fibers have an action potential that lasts from 0.3 to 0.5 milliseconds. This is gonna vary from time to time. What does it depend on? On heart rate. Heart rate is gonna be a key component in the duration of the action potential, because some action potentials are gonna last shorter. That's when the heart rate is gonna be really fast, that your heart is gonna be pumping really fast, like when you're exercising. That's when the heart is gonna be pumping more blood. It's gonna be needing to contract a lot more times during 1 minute. So the action potential is gonna last less. What's the part of the action potential that actually is the one that's shortened? It's not so much depolarization or repolarization. It's gonna be the resting period, phase 4, the resting potential, okay? We're gonna have it divided into 4 different phases. First, there's gonna be a rapid depolarization, where fast sodium channels are gonna open, and sodium is gonna go into the cell as fast as it can. This is gonna make the membrane of the cardiac cell, it's gonna make it positive, okay? Because a huge flux of sodium is going into the cell, and it's gonna, in the chart you can see, it's like in a spike. It's completely longitudinal, how it climbs. Then you get to phase 1. In phase 1, it's initial rapid repolarization. Here, fast sodium channels are gonna close. So no more influx of sodium into the cardiac cell. However, there's another cation that's going into the cell. It's gonna be calcium. Calcium is super important in cardiac muscle, okay? It's gonna be one of the most important ions you can have. What's calcium gonna do? Thanks to calcium, the plateau right here that occurs in phase 2, it's gonna occur. Why is that? In the rapid depolarization that you can see right here, some of the slow calcium channels are starting to open. It doesn't do much for the depolarization, but when it gets to phase 1, to the initial rapid repolarization, instead of going back down like in the skeletal muscle, it creates a plateau thanks to all those slow calcium channels that open and let the calcium influx in to the cell. So even though potassium, it's going a little bit out of the cell, thanks to calcium that it went in through those channels, you can have a plateau created that's going to make the action potential last longer, different to other cells. Right here, you can see that potassium is going to start to go out of the cell. However, thanks to the calcium going in through those channels, not so much potassium is going out, because the calcium changes the permeability of the membrane to potassium. So even though the channels are open, the potassium channels are open, not so much potassium is going out, also contributing to the phase 2, creating that plateau, okay? Then there goes slow repolarization. What happens here? Well, calcium channels close. So now that they're closed, potassium can flow completely naturally out of the cell. So boom, all the potassium starts going out of the cell. Rapid repolarization, that gets us to phase 4. That's the resting potential, where we get back to minus 90 millivolts of membrane potential. Okay, this is gonna last, as we said, from 0.3 to 0.5 seconds. Here, in this chart right here, you can see the difference of what I was explaining to you. Skeletal muscle has a rapid influx of sodium and a rapid deflux of potassium, causing it to look like a spike. It just looks like a triangle. However, in cardiac muscle, you have a plateau. So it's very different, the shape and the duration of the action potential. We already reviewed it a bit, but let's check it again. This right here goes for all the cells except the specialized conduction fibers. They act differently. They have a rhythmicity, okay, that we're going to review in a while. But just remember, this goes to all of these cells of the atriums and the ventricles, but it doesn't apply to the specialized conduction system. Where does it begin? As you can see in the GIF right here, it all starts in the sinoatrial node, SA node, then travels through the Thorel, Weckenbach, and Bachmann branches, anterior, medial, and posterior. Then goes to the AV node. The AV node is right here. Then travels to the His bundle that has a left and a right branch. And then it gets to the Purkinje fibers. The Purkinje fibers have a very fast conduction. So they're going to take the depolarization that's being transmitted to them to all the rest of the cardiac muscle cells, and acting as a syncytium, the heart is going to contract in kind of a spherically way. Okay, it doesn't contract like this. It contracts like this, like twisting, so all of the blood can go out. Can everyone still see the presentation?
Yes.
Yes, we can see it.
Okay, perfect.
Yes.
Because my computer is lagging a little bit. Okay. So we're going to talk about the cardiac pacemaker. Okay, the specialized conduction system is a pacemaker. What's a pacemaker? A pacemaker is going to be some cells that trigger a rhythmical discharge after every action potential. So as you can see in the chart right here, after every action potential, a new one starts. And it's going to start with a rhythm. It doesn't need for an outside stimulus to create this action potential. It creates it by itself. All coming from the physiological pacemaker that is the SA node. However, in some pathologies, we can have other pacemakers. like the AV node, it can become a pacemaker if the SA node has some type of pathological manifestation going through it. If the AV node works fine, it's not going to be the best pacemaker, but it can work, and it can make it work for that person. Okay, so we talk about the SA node being the pacemaker, the original pacemaker. And these cells, as you can see right here, by an influx of calcium, again, calcium is the most important ion, it's gonna go from -60 to -40, where the threshold is approximately in. These slow calcium channels open by themselves. They don't need another stimulus. Every time an action potential finishes, they just start opening again, slowly, gathering calcium, until it reaches the threshold. Then fast calcium channels open. These calcium channels are going to take, again, depolarization. The action potential is going to go positive to 20. And then instead of a plateau, potassium is just going to go out. Here we don't have that much sodium acting like in the other action potential, like on the rest of the cells. Here we just have calcium and potassium. So calcium enters through slow channels and fast channels, okay? And after these channels get to the positive side of the action potential, potassium channels open, potassium goes out of the cell, and the action potential finishes. Then again, the cell starts taking calcium, starts taking calcium. It gets up to another threshold, and from the threshold, it goes up, and that's the rhythm it's going to have. This action potential is going to travel to the rest of the cells, which are going to have the normal action potential we saw before. Okay. A type of innervation is needed, including for these cells. We're going to have two types of innervation that goes to the cardiac cells: parasympathetic and sympathetic. Okay? Parasympathetic, it's going to be to the vagus nerve. As you remember, one of the cranial nerves, the left one, it's going to stimulate the AV node. And the right one, it's going to stimulate the SA node. And the sympathetic stimulation the heart's going to have is through the stellate ganglion. The stellate ganglion, as we can see it right here, is going to be found in the brachial plexus. This one, what's the effect of the sympathetic tone and the effect of the vagal tone going to do? The vagal tone, it's gonna, as you can see here in the action potential, it's gonna elongate it. So it's gonna cause a depression of the cardiac contraction and the rhythm. It's gonna make it go slow. And the sympathetic effect that the innervation has, it's gonna make it go faster. It stimulates the tropisms. Parasympathetic, as we know, works through acetylcholine, which is going to increase the potassium conductance. So potassium, what does it make? What does it do to the cell? What does it do to the cardiac cell? What it does is it shortens, it makes the current of calcium slower, and it decreases cyclic AMP. By decreasing cyclic AMP, you make the calcium channels open even slower. So the rhythmicity is going to go slow. The rhythm is going to decrease. So that's why we say that parasympathetic stimulation of the heart causes chronotropism, dromotropism, plasmatropism, and lucitropism to go down. And on the other hand, we have sympathetic stimulation. Sympathetic stimulation is going to work through noradrenaline. This, on the opposite hand, it's going to increase intracellular cyclic AMP, and it's going to make the depolarization go faster. Which receptors are going to be stimulated in the sympathetic intervention. Well, we know noradrenaline works to the beta-1 receptors, and the acetylcholine works to the muscarinic type 2 receptors. So the beta-1 receptors, what effect do they have on the heart? They increase chronotropism, they increase dromotropism, they increase bathmotropism, lusotropism, and inotropism. So we're going to have a heart that contracts stronger, that contracts faster, thanks to the beta-1 receptors. A lot of medicine is targeted to these receptors. Medicine that's for arrhythmias, that's most importantly for hypertension, and you're going to see them in some of the semesters they're going to come. But if you learn this type of receptors, you're going to know what kind of effect you're going to have on the heart. If you block these receptors, then you're not stimulating chronotropism, dromotropism, inotropism, etc. Okay? So molecularly, beta-1 receptors, we're going to have that they make the L conducts. L conducts are the channel conducts. They're the slow channel conducts. They're going to make the slow calcium channel conducts open easier. So by opening easier, more calcium into the cell, and that's how they stimulate all of this. Okay? Thanks to cyclic AMP. Cyclic AMP stimulates the L conducts. L conducts are calcium conducts. Just remember that. Okay, there it goes. So, as I told you before, the different structures of the heart have a different conduction velocity. The SA node, it's not the fastest. It just travels to less than 0.01 millimeters per second. In the normal heart rate that SA node can have is from 60 to 100. Of course, in some periods, we're going to have compensation the SA node can do. So it can go to tachycardia, that's going to be over 100, or bradycardia, that's going to be under 60. And that doesn't mean that we have another pacemaker coming in through. It just means that the SA node, it can adapt. However, the SA node, it cannot go that much faster or that much slower. As we said, atrial myocardium is not part of the specialized conduction system, so it doesn't have a pacemaker rate, a pacemaker rhythm, but it does have a velocity because the syncytium can pass the stimulus, can pass the action potential to other cells, and it's going to be a lot faster, for example, than the SA node. I'm sorry, slower. It's going to be slower than the SA node. The AV node has a velocity of 0.02 to 0.05. The his bundle is low, has a velocity of 1.2 to 2 seconds. The different branches of the bundle of his pretty much have the same velocity. Then we get to the Purkinje fibers that almost have this same velocity. His bundle, the branches in the Purkinje network can have a pacemaker rhythm, but as you can see here, it's non-compatible with life. You cannot survive with 25 beats per minute on a prolonged period of time. So we're gonna know that the most common ones we're gonna see at the clinical practice are gonna be a sinus rhythm or an AV rhythm. Also, something to know right here is that depolarization in the atriums is gonna be completed 0.1 seconds. In 0.1 seconds. At the AV node, a delay is going to occur. What was this delay for? For this fibrous ring that's right here, these fibrous rings, and that the AV node causes a delay of 0.1 seconds before it gets to the ventricles. The heart rate. What's the normal heart rate? 60 to 100. We already reviewed that. In the clinical practice, you're always going to say that's from 60 to 100. 70 beats per minute, it's the average at rest. However, from 60 to 100, you cannot say it's a normal. You can say, you're always going to say it's normal. And as we said before, the physical activity is going to have a huge impact on this heart rate. Sometimes it can even go up, sometimes it can even go down by rest, and it's going to be the compensations and through the innervation that we saw through the sympathetic and parasympathetic systems. So what we can here see most importantly, the heart as a pump. What's a pump? I think everyone knows that. A pump, it's a mechanism that pushes something through somewhere, okay? Like for example, when you have a ball and it's deflated, you need a pump to get air into it. So the pump of the body is the heart, which it's gonna push the blood all around the different tissues. As we said before, we're gonna divide the heart into different chambers. The right chamber is gonna push the blood into the lungs, okay? Through the pulmonary arteries, not the veins, the pulmonary arteries. It's the only arteries in the body they're gonna have deoxygenated blood instead of oxygenated blood. And then from the blood travels from the lungs through the left chamber of the heart, which is gonna push the blood into the peripheral organs and tissues. The cardiac cycle is going to be divided into two most important phases: diastole and systole. Diastole is going to be the period where the heart is relaxed. All of the muscle fibers in the heart are going to be relaxed. The atrium muscles are going to be relaxed. The ventricular muscles are going to be relaxed. And what's going to happen here? That allows for the pressures to go down, because in any chamber we have a pressure, and to put something into it that has a flow, we need pressure to go down. So when diastole occurs, pressures go down, there's no contraction, and the blood is able to fill the chambers. Diastole is when the AV valves are going to be open, and the semilunar valves are going to be closed. Blood is going to go from the veins, from the pulmonary veins to the left heart, and from the pulmonary and from the anterior vena cava and from the posterior vena cava, it's going to go to the right chambers of the heart. It's going to go without any mechanism. It's just going to flow, because that blood has a flow through the pressures we know. It has a flow, and it's going to start filling the heart. First, it's going to fill the atriums, and then it's going to go through the ventricles. It doesn't have to always be through contraction that the ventricles are filled up. Blood can flow through because the AV valves are open. So blood's going to come right here, but it's going to go until here, okay, without any need of contraction. And this passive filling, that's what we have here, that's what it's called, passive filling. It's how the ventricles are filled up to 60 to 70%. In fact, we could survive with just with that passive filling alone. We don't need for the atriums to contract and fill the blood at rest, at least. At rest, we're not going to need for the atriums to contract and fill the rest of the blood of the ventricles. We could just do fine with the blood that's going through thanks to passive filling. However, the body always creates more in case you need more. So ventricular volume at the end of diastole is going to be of 130 milliliters, okay? 110 to 120 approximately. Then what happens? As we said, the action potential starts going through. First, it occurs in the atriums, so the atrial systole, okay? Atrial contraction is going to push the remaining blood into the ventricles. So here, the AV valves are still open. What's going to happen? The only thing that's going to happen is that the pressure, thanks to contraction, the pressure in the right atrium is going to go from 4 to 6, and in the left atrium is going to go from 6 to 8. So as we said before, the pressures in the atriums is less than the pressures usually managed in the ventricles, because the ventricles have so much muscle that they can create higher pressures, because they have to go through higher pressures to push the blood into the body. So during this contraction period, during the atrial systole, the holes that the cava veins have are gonna narrow a little bit, so there's not that much reflux. However, some reflux is gonna occur because, well, it's not a perfect system. You don't have any valves there. It's just through pressures, but it's gonna be a very little amount, the reflux that the atriums are gonna have to the veins. Also, what's gonna occur first? The right atrium, it's gonna contract a little bit before the left atrium, okay? Just a tiny bit. That's just like physiologically, the right chambers contract a little bit earlier than the left chambers, just as the left chambers have higher pressures. So then what occurs? Now we have a heart that the atriums don't have blood because they contracted the rest of the blood they have, and we have 2 ventricles that are filled with blood. Then what happens? Systole, ventricular systole. The AV valves close. We need them closed in this period, because if they're not closed, then a reflux is going to occur that, as we said, the ventricles can manage higher pressures than the atriums. So if they don't close, a huge reflux of blood could occur to the atriums, and we don't want that. That would be a pathological state. So here the AV valves close, and isovolumetric ventricular contraction starts. What's isovolumetric ventricular contraction? It's when the contraction starts to occur during systole, okay? It's not when the blood is pushed out of the ventricles, it's just when the contraction starts to occur in the pressures within the chambers, within the ventricles. It's gonna pump, it's gonna spike up to beat the pressures in the aorta and in the pulmonary artery, okay? So the aorta, here it's backwards. The pulmonary artery has less resistance than the aorta. I'm sorry. The aorta is going to have an average of 80 millimeters of mercury of pressure. So the left side of the heart, the left ventricle, has to contract to somewhere over 80, so blood can be pushed out. And in the right chambers of the heart, that right ventricle is going to have to contract to a point where the pressures within the ventricle are higher than the 10 millimeters of mercury of the pulmonary artery. Here it's backwards, okay? So don't get confused, please. And how much time does it last? It lasts about 0.5 seconds. So systole, ventricular systole, is what lasts longer in the cardiac cycle. Okay, then what happens? As we said, first the ventricles start to contract, then we get to that point where the ventricular ejection occurs. That's when the blood is finally being pushed out of the chambers. The semilunar valves are going to open. The semilunar valves, they're different from the AV valves. They don't open during diastole. They just open due to the difference, the gradient of pressure that occurs between the ventricles and the arteries, the pulmonary arteries and the aorta. So they need a high pressure. They need something very powerful to make them open and let the blood go through. It's going to be fast at the beginning, and then the contraction is going to become a little bit weaker, so it's going to diminish a bit. So most of the blood, what does that tell you? Most of the blood comes out at the beginning when the pressure are at its peak. When the pressures are the highest, then when most of the blood is going to go out, and then it's going to diminish a bit. As we said, the maximal pressures the ventricles have to go through, the right ventricle has to get to a pressure of about 25 millimeters of mercury during this period. During ventricular ejection, that's the pressure that the chambers go through. They climb a lot. So from a state of about almost no pressure, because the atriums have to push blood into the ventricles, and if there was a lot of resistance, then we wouldn't have that much blood going through the ventricles. It has to climb up 25 times the pressure it had. And in the left ventricle, it's gonna be a lot of times more. It's gonna be 120 millimeters of mercury to what it has climbed. And what does that tell you again? It occurs the same thing that in the atriums. The right ventricle is gonna start before than the left ventricle, just a little bit. But what's that? Why is that? It is because the pressures, one has to get to 25, the other one has to get to 120. There's a huge difference right there. Then what's the amount of blood expelled by the ventricle? It's going to be from 70 to 90 millimeters approximately. The ejection fraction, we're going to calculate it like this, where we're going to have the stroke volume. Stroke volume is the amount of telediastolic volume left in the left ventricle, in the right ventricle. So the stroke volume is going to depend on how much blood it gets to the ventricles, and then by the contraction, how much leaves the ventricle. As we can see here, the ventricle, as we saw before, it gets to 130 millimeters of blood. However, it just pushed 70 to 90. Why doesn't it push the 130? Because we have some blood left in the ventricle. All of it cannot be pushed through. Sometimes more than 70 can pass through if the contraction is really strong. Sometimes even just 20 milliliters of blood can be left in the ventricle. So it could be like 100, 110 maybe, but the normal is 70 to 90. So the ejection fraction is a percentage. It's about 60 to 70% of the end telediastolic volume, okay? So as we can see, the ejection fraction is just going to be calculated as ejection fraction equals stroke volume. Stroke volume, remember, is the volume that's being pushed over divided by the end diastolic volume. And what's stroke volume again? Stroke volume is the end diastolic volume minus the end systolic volume. So stroke volume, let's just get an example. If we have a heart with 130 milliliters, 70 get pushed through, 70 get pushed through, and 30 are left in the heart. That means that we're going to have a stroke volume of 70. Wait a second, I'm not good at math, I'm sorry. We have 130 minus 70, that leaves us 60, and 30 is what's left in the heart. So we have a stroke volume of 100. Okay, everyone gets it? And what does that mean? We have a high function, a normal function, a low function, and a possible heart failure to classify all of the categories of heart failure. So a normal human being, as we said, needs to have an ejection fraction of 70%. However, in some people, it can get to less than 40, it can get to less than 60, it can get to less than 50, and then clinical symptoms start to appear. That's when the stroke volume has been diminished. If the ejection fraction was diminished, that means that the stroke volume, the total amount of blood being pushed out of the ventricle, that's what the stroke volume is is less than in a healthy human being. So instead of 100, we're going to have maybe instead of 70 to 90, 70 to 100, we're going to have maybe 50 milliliters of blood pushed out, a stroke volume of 50. Maybe we're going to have a stroke volume of 40, maybe a stroke volume of 20. Who knows? We're going to hurry up this a little bit. What's next? Protodiastole. What's protodiastole? After a ventricular contraction, there is a quick fall in pressures. So ejection occurs, then protodiastole. Proto means beginning. So it's the beginning of diastole. This is where the semilunar valves are going to close again because the pressure start going down, are going to start to go down, and isovolumetric ventricular relaxation occurs. So this is where the pressures keep falling after the semilunar valves are closed, and they become less than the pressures in the atriums, as we said before. So here we're going to have a circle that's going to connect maybe things a little bit better so you can understand better. As we said, for everything starts with diastole. Here is where ventricular filling occurs. Then we go to atrial systole, just atrial systole. All the rest of the heart is still in diastole. Then we're going to pass to isovolumetric contraction, ventricular contraction. That's when systole in the rest of the body starts. Then we're going to have ventricular ejection, and then isovolumetric relaxation. That's when the diastole starts again. This is going to have different patterns. As we know in the electrocardiogram, it's very important for the clinical manifestations of this conduction system. The P wave, it's going to be the depolarization of the atriums. The QRS complex, it's going to be the depolarization of the ventricles. And then the T wave, it's going to be the repolarization, the isovolumetric relaxation of the ventricles. Why don't we see the wave of the repolarization of the atriums? Because it's hidden under the QRS complex. What's the cardiac output? The cardiac output, it's going to be the total amount of blood that's going out of the heart, okay? It's going to be approximately 5 liters in a healthy man, in a 70 kilogram healthy man. And from here, we can take the cardiac index. Cardiac index, it's almost the same as the cardiac output, except that it's the cardiac output divided in minutes and divided into square meters of body surface, okay? So what's going to increase the cardiac output? Anxiety, excitation, eating, exercise, high temperatures, they're going to increase the cardiac output. So that means a higher stroke volume. So more blood is flowing through the body in 1 minute. And what's going to diminish the cardiac output? Sitting down. If you're standing up, your cardiac output is higher. Fast arrhythmias can diminish your cardiac output, and cardiac disease can also change this, okay? Then we're gonna have another very important subject we have to address: preload and afterload. Preload, it's gonna be the force of it's going to be the passive stretching of the muscle fibers in the ventricles, which is going to allow from blood to fill the ventricles at the end of diastole. And afterload is the pressure that the ventricular muscle has to overcome to push the pressure, to push the blood, create higher pressure to push the blood out of the aorta. So the force of contraction is going to depend on this too. As we're going to see here, preload, it's very related to the law of Frank-Starling. And what changes preload and afterload? Preload, here's an easier definition: volume of blood in the ventricles at the end of diastole. It's going to be increased. It's going to be increased by hypovolemia, regurgitation in the cardiac valves, heart failure. And afterload is the resistance left in the resistance the left ventricle must overcome to circulate blood. It's increasing hypertension. In hypertension, the blood vessels have a higher tension, so more pressures and vasoconstriction. More afterload equals more cardiac workload. Why is that? Because then the muscle of the left ventricle has to get stronger to push the blood over even higher pressures than the physiological ones. This is very important in a pathology called heart failure, but hypertrophic heart failure. That's when the body, especially in hypertensive patients, the afterload is increased for many, many years. So as any other muscle, when you work out, you make your muscles bigger. That happens, the same thing happens with the heart. It's still a muscle and it's very similar to skeletal muscle. So it's gonna become bigger, bulkier, but it's gonna lead to some other pathologies like diminishing the amount of blood that can get to the chambers of the heart. So we're gonna have that cardiac output. This is in Spanish, I'm sorry. Cardiac output, it's gonna be determined by heart rate and stroke volume. Why? Because stroke volume is the total amount of blood that is ejected in one beat, and the heart rate is gonna be how many beats per minute we have. So we have a stroke volume of 70 and a heart rate of 100. We're gonna be pushing around 7 liters of blood. Okay. Then the cardiac output, it's also gonna determine the arterial pressure. If we have a higher cardiac output, then we're gonna have more blood pressure in the vessels. Okay. And what changes the stroke volume? As we saw before, afterload and preload change the shortening of the myocardial fiber. Why is that? Afterload, because it creates a bulkier muscle myocardial fiber, thanks to all the, if it's in a pathological state where it has to get bulkier, the muscle fiber is going to get bulkier, and the contraction is going to be stronger. And preload, because of this, because of the Frank-Starling law. The Frank-Starling law, imagine a slingshot. Everyone knows what a slingshot is, right? A slingshot depends how far you're going to throw the rock you put in the slingshot. If you just pull a little bit, the rock or the thing that you're going to fire to someone, it's not going to travel that far or that fast. It's not going to have that much power. However, if you stretch to the highest point the slingshot, then the rock you threw can fly a long distance and with a lot of power. The same thing happens with muscle fibers. If muscle fibers are stretched more during the preload, they're stretched more, they're gonna contract even stronger. That's the law. It's gonna be some exceptions like dilated hypertrophy, cardiac hypertrophy, okay? That's when the heart, it's hypertrophic, but the walls are very, very, very thin, so they don't have a lot of power of potential of contraction. However, in all of the people, if you get more volume and stretch the fibers a lot more, the contraction is going to be more powerful thanks to this law. So that alters preload. And what's left? Heart sounds. As we reviewed before, the heart's going to make different sounds. It's a machine. Machines make sounds. We're going to have the first sound. That's the closure of the AV valves, followed by the opening of the semilunar valves. It's going to sound like a lup, lup, lup. And we're going to have the second sound, that is the closure of the semilunar valves, followed by the opening of the AV valves. And it's going to be named a dub. Okay? That's how literature describes this sound. Why do they occur? The closure of the valves makes a vibration occur, that it travels, and that's what you can hear through your stethoscope. However, we can have other sounds. We're going to call them gallops. S3 and S4. S3 is going to happen after The second sound, it's going to happen 1/3 of the way through diastole. And it's most common to hear on children and young adults. However, it's not pathological always. In a 50-year-old fat human being, it's going to be something of suspicion. It's not going to be okay. But in a child, in a teenager of 17 years old that's skinny, it's not going to be a problem. It can be physiological. And what happens here, the turbulent flow that happens during the ventricular filling is going to create a sound. S4 occurs before the first sound of the heart, a little bit before. It's going to be of low frequency, and it's rare, and it's also due to turbulent flow, okay? And let's just finish this with a fast review of the whole presentation, okay? If you can see in this map right here, everything we talked about is put into here, where you can see the different periods of the heart and how they evolve in the different graphs. Let's start with what was the first part, diastole, with the atrial and ventricular filling. That's gonna occur right here. The ventricular filling and the atrial filling. This occurs during diastole. Then systole is gonna occur, and the pressures in the atriums are gonna spike up a little bit. Right here you can see the little spike of the pressure they have, and the AV valves are gonna close. This fills the remainder of the ventricles. Then isovolumetric contraction is gonna occur, and you can see here the pressure in the right ventricle. It's gonna go boom to 120 millimeters of mercury. That's a lot. Then isovolumetric relaxation is gonna occur, and the volume is gonna start to go down. That's when the aortic valve here around 90, it's gonna open. Around 90 again, it's gonna close, creating the sounds, the dub, the lub, dub, as you can see here, the lub, AV valves close, dub, aortic valves, semilunar valves close. So as you can see here, the machine, it's all related, okay? And here you can see it in a faster motion thanks to this GIF video. So everything we talked about, if you can just review an image like this and understand it a little bit, everything's related. We can see here in the electrocardiogram, depolarization of the atriums. That's gonna coincide with the atrial systole. It's when the pressures of the ventricle of the atriums are gonna go higher. After this, they're gonna close. Then ventricular systole is gonna occur. The QRS complex, it's gonna appear. Pressures in the ventricles are gonna go up. The semilunar valves are gonna open. Then they're gonna close when the isovolumetric relaxation starts to occur, and the spike starts to go down. In this cycle, it's gonna repeat itself one and again and again and again and again. Okay, so we're gonna leave you some activities. They told me we have to leave you with some questions. I thought the easiest questions you could have was first explain the intervention of the heart that we reviewed at the beginning, and also mention the phases of the cardiac cycle. Okay, just mention them. We reviewed it at the end. They're right here, so you can have a fast review. Check them at your homework. And right now we're gonna start taking some questions if you want, so we can end the presentation, right? So thank you for your attention, and here are the references from where I took the information. So thank you a lot.
Thank you, doctor. Thank you so much. I think in the chat is one question. I don't know if you want to read it.
I'm sorry, I didn't see the question.
No, it doesn't matter. Just write it down.
Let me go to the...
And if anyone wants to ask something, you can write it down on the chat. Remember, these webinars is for giving some knowledge for the classes, but it's also is really helpful for improve our English. So please don't feel judged. Anyone can ask. So please feel free of doing it.
Just 1 minute. How do you enter the chat again? I'm sorry.
You
Oh,
got
I see it.
at the bottom. Yeah.
Right. I'm sorry. Okay.
The question is from Arturo Bugarin. I don't know. You can see it.
Arturo.
Can we talk?
I'm sorry, I don't see the question. Let me just look.
Yeah, you can talk, Arturo. You can open your microphone, please.
Yeah, I have a couple of questions. You said S4 is a sound that is just caused by some influence of the turbulent in the bulb, right?
Yeah, the S4, it's gonna be caused by turbulence in the flow, not the bulbs, in the flow. And most of the time, it's gonna be pathological, but it's not always. Also, in young people, it's more normal for it to happen, but it's very rare in adults. It's actually very rare in normal adults.
How it can be normal?
Well, that's how how can I explain it? It's not gonna, because of the mass that we have as an adult, it's more than the mass that the children or little kids have.
Mm-hmm.
You're not gonna hear it. There's always gonna be turbulence, because any liquid that crashes with walls, it's gonna create turbulence, okay? However, healthy individuals, especially adults, have more mass, muscle mass, fat mass, whatever you want. So it's not gonna be normal for it to hear it. It's gonna be rare in normal adults to hear it, because they have to be very skinny, and that's when you can hear it. If you hear it and it's in a pathological state, it's by something that's causing more turbulence, okay? What could that be? Maybe there's some damage in the valves. Maybe the muscle is hypertrophic, okay?
No, it's because I think the S3 sound is due to that things that you're saying. Left ventricle dilated, maybe stiffness. But I've read that S4 is mostly created by the more accentuated atrial kick. So that's more my question. I read that it's always pathological. That's why I was really curious about the moment in which one it could be normal. But thank you.
No, it's okay. Well, that's what the Guyton of Physiology, the book, was reviewed. But it's a good question. It's valid for it to be reviewed over. If you want, I can check the question, and if you put here in the chat some contact or something, I can check the answer for you, because I don't have it technically at the moment. That's what especially Gannon, that's where I took most of my information. That it gave me that information, okay? But I can review it and tell you in which cases it would be normal, because yes, I agree with you that it's practically pathological. However, I put it in there because as the Guyton and Gannon, in one of those books, it said that it could be rare in normal adults.
Yeah, and another one question is that you said that mostly right part of the heart contracts first than the left part of the heart. Is that true?
Yes, that's true. The right part of the heart are gonna contract just a tiny bit earlier in the atriums and in the ventricles. But more that contract is that they finish their contraction a little bit earlier. Why? Because they don't have that much pressure to overcome. If you compare it to the left chambers of the heart, they have to beat pressures of higher, the left ventricle of 190 millimeters of mercury, and the right ventricle, I'm sorry, it just has to be a pressure of 15 to 20, okay?
Yeah, but actually my problem is the following. From that point of view, saying that I'm sorry, right part of the heart contracts in the first time, and the second time the left heart, how would you explain a paradoxical split during inspiration and expiration?
Can you repeat the question? I didn't hear it
Yeah.
well enough.
From what I have read, a paradoxical split is this switch in which, because a conduction disruption, the right side contracts first, then the left, and from that point of view, that's not normal. I have read the opposite, that the left side contracts first, than the right, so we can explain, well, mostly why the valve closes first in the pulmonary, or why does a paradoxical split exist. So
It's not that it, I think I was a little bit misunderstood here. It's not that it just like 0.1 seconds before it contracts. It's not even referred in the literature. It's not even referred as a it doesn't even give you a exact time of how much earlier does it contract. It just mentions it because it's mostly by the tiny bit of time that it takes the left ventricle, the left chambers, to overcome a higher pressure. So they actually, yeah, the paradoxical state is always going to occur during respiration. Physiologically, that's always going to happen. However, it's not. How can I explain? It's not like 0.1 seconds. I said, told you before. It's not that's going to occur that much faster. It's just. It's not even the time given. It's just how literally mentions it. Literature mentions it that the left chambers take a little bit more time to overcome those pressures.
Okay, thank you.
Thank you so much for the question. I don't know if anyone has more questions. One thing they are asking for it, if doctor, you can, I don't know, give us your presentation, or give us even your email, and anyone can ask for the presentation of any question.
Yeah, I can give you the presentation so everyone can have it and take notes from it. So yeah, it's not a problem. Yeah, I can pass the presentation to everyone.
Thank you so much. And if no one has a question, I will have one. You know, we have students from medicine, nutrition, and gerontology. And
Okay.
I think one of the important question is how old people, or the fact of being elderly people, can affect to the regular activities of the heart. How the age affects the activity of the heart. Getting old, how affects that?
Yeah. Well, as we know, getting older affects all the mechanisms in the body. First of all, if you check, especially here in Mexico, the higher the age, the older the person, it's more common for some things like hypertension, so by like early stages of heart failure to occur. So in elderly patients, where we're gonna see that some patients don't have the same function as a normal, healthy, younger heart. Not that it's pathological per se, but more that the heart, it's an older person. It's gonna have some hypertrophy, most likely. It's gonna have some chambers, especially the left chambers that have to push higher pressures. Most of the time, they're gonna have a little bit of hypertrophy. Maybe the valves have some not huge damage, but some kind of damage for all of the flow and all of the years they have worked. So yeah, in the action potential, maybe there's a relative bradycardia compared to to healthier younger patients. But it's not going to be like, if it's a healthy elderly patient, then that means that the physiological mechanisms of his heart are working fine. So he doesn't have a huge problem. He doesn't have a bad heart compared to a younger one. It's not gonna be working as good as new, like everything else. They don't work. If you buy something, maybe it was good when you bought it and it's in perfect condition if you maintain it very well, but it's never gonna be the same as a new one. So maybe some part of the muscles, maybe some fibers don't have the same power as they had when they were younger. They don't have the same contraction power than they did when they were younger. Maybe the fibers, they cannot stretch as much as before, or maybe they're stretched and they cannot contract stronger again because they are stretched more than it could happen. But in elderly patients, you're gonna have some clinical variations as everything you do. They say in medicine that pediatrics and in gerontology, in heritology, it's completely different stages of the life. So you're gonna have some wiggle of permission to say that's a healthy heart. It's a healthy heart for that age of a patient. If he was 20, maybe you could worry a little bit because it's not as healthy. But since he's old, he's maybe 70, 65, 80 years old, you're gonna be like, okay, for an 80-year-old man that has a life expectancy of not more than maybe 5-10 years, if he's super healthy, you're gonna be like, his heart works fine.
Okay, thank you so much. So I don't know, I think we have time for one question because it's a little bit late for everybody. So if you don't have a question, I don't know if
yes,
you
I
can
have
write.
one.
Okay, Jose Manuel, please do your question.
Okay.
Good night. First of all, I'd like to apologize for my lack of vocabulary. I'll do my best to make myself clear.
Feel free for
No, it's
doing it.
okay.
I have my question. Does being skinny have a direct relationship to having a higher pulse and respiratory rate? Because I read about thermal and metabolism recent. So I'd like to know if there's any way that it can be related to the mechanical activity of the heart.
But by a higher pulse, you mean that you can feel the pulse, or a higher that's higher higher rate?
I'm a skinny guy. Yeah, I'm a skinny guy, and I can almost feel my heart pumping out of my chest.
Yeah. Well, first of all, if you remember or I don't know if you've seen it enough in this grade that you're in, but then you're gonna see that the apex of the heart, in some patients, you're gonna feel the vibrations of the heart. So you're gonna feel the beats of the heart in some patients. Why is that? It's because the heart, when all of the mechanisms it has, it creates vibrations. Okay, it correlates a little bit to the question that was asked before, that yes, in the skinny patients, and especially you're young, your pulses, they don't have to travel to that much tissue. You don't have any fat. Okay, so the vibrations are gonna be felt a lot more. Okay, so if, for example, you're a skinny guy and you go to your fifth intercostal space at the middle linear line, okay, you're gonna feel the palpitations of your heart. You're gonna feel the beats of the apex. This is normal in young patients like yourself and in skinny individuals, because, for example, if you weigh 100 kilograms and you feel the vibrations, it means that he has a huge heart. Okay, because he must have a huge heart and create a huge contraction power so that vibrations can go through all that mass of tissue and still be felt. I don't know if I answered your question.
Yes, because I thought it could be a medical issue, since the difference between skinny people and general population is very small.
If you feel it a lot, like maybe, yeah, it's okay to take an electrocardiogram, see if it's not a hypertrophy in the muscle. However, in young skinny individuals, it's always going to be normal for some kind of stronger pulse to be felt.
Okay, teacher, I really appreciate your answer.
Thank you so much. So anyone, another question? You can write it down and open your microphone. Well, doctor, thank you so much. I don't know if you can write it down in your in our chat, your email. So
Yeah, sure. So if you,
please, so everybody can reach you if have any question.
and Arturo, if you want, I'm gonna try. You can send me your email too. I'm not a cardiologist. I'm gonna try to talk to some to express the question that you asked me. Maybe in some cardiology books the answer you have is more correctly found, so I can answer it better. And if you pass me your email, I can answer that question too. I can look for the answer if I don't have it for you.
Yeah, thank you. This is I read from Born, so sometimes that book is kind of I don't know, so say some different things.
Can you say that again? I didn't hear that.
Yeah, I'm sorry. Most of what I have read about physio is from Born. Physio from Walter Born is a really huge book, and sometimes that book is like confusing, contradictory. So, but thank you for that.
Okay, I'm sorry. I didn't check that book. I didn't know of it. Mostly, I did my research on Ganon and Gaiton, that are like the most famous ones. However, I'm gonna try to look for that question, for that answer for you, and pass it maybe later through the presentation. If I'm gonna pass the presentation to you guys, maybe I can write a note right there to specify the answer.
Okay, thank you so much. So I want to thank everybody again for being here, and I would like to invite you to the next webinar, the next Wednesday at 7 p.m. is appendicitis. I think is the next topic. So thank you so much. Thank you so much, doctor, for being here and give us so much information about the mechanical activity of the heart. So thank you so much.
No, thank you for inviting me, and I hope you could understand everything that was said. And I'm gonna pass you the presentation so you can share it.
Thank you so much. Thank you so much. So thank you, everybody. Have a good night. Bye.
Bye. Thank you.